I was going to give prepared remarks, but so many other people have spoken today that I'm going to try to fill in what I see as some potential areas that we could further address. You heard a really compelling story of what this disease is like for patients, and I especially want to focus on the post-exertional malaise and the cognitive dysfunction, because those are profound symptoms for patients, and it doesn't take long to know which patients have ME because of those dysfunctions. Chris Snell has said that using cardiopulmonary exercise test, you can actually distinguish between patients with ME and patients with depression, deconditioning, and a number of other chronic illnesses. And yet, there's a lot of confusion in the medical community. Why is that? The reason is because for 30 years, we have used definitions that fail to require, and we're still using these, fail to require these hallmark symptoms. We allow patients to have any combination of four, as Jenny said, any combination of the 4 out of 8 symptoms of Fukuda. Lenny Jason has shown how we end up with depression, deconditioning, and other medically unexplained fatiguing conditions mixed in with ME. No wonder doctors are confused. Every patient will tell you stories about going to a doctor and a doctor tells them he needs talk therapy. My son was recommended that he get exercise because of what is on the medical education sites. He crashed when he went back and told the doctor. She said, I can't tell you how important it is you continue to exercise. He woke up with this disease on May 19th. If he had been told to look out for post-exertional malaise based on the symptoms he had, he would not have climbed Mount Washington and ended up even sicker than he was. The second thing that I want to speak to, I want to add one other point there. It's important to realize this doesn't just affect ME patients. 30% of MS patients end up with a diagnosis of chronic fatigue syndrome before they ever get diagnosed correctly with MS, because this is a waste bin diagnosis. If you have fatigue and you go to the doctor, they're going to tell you you have chronic fatigue syndrome. The American Family Physician says that patients will do better. They have a poorer prognosis if they think they have an organic cause for their disease, if they have maladaptive social adaptations, they're not able to relate to each other socially. This is crazy. Why are we doing this? The second thing, the question that I want you to all keep in mind in this committee is exactly what disease are you talking about here? Exactly what disease are you studying? Are you studying the ME that every single patient here talked to you about today? That every single patient here is going to go home and crash from post-exertional malaise from having been here? Or are you studying the set of all the conditions that meet the Fukuda criteria? Remember, they're not the same. They're very different. We heard today about, quote, CFS being heterogeneous. Of course it's heterogeneous. You throw all these things together and you're going to end up with heterogeneity. But it is man-made heterogeneity. It's not real. ME is heterogeneous. ME is heterogeneous. It's a very complex disease. It depends on how long you've had it. It probably depends on what your sex is, what the trigger was, and any number of combinations. But that is not the same as the kind of man-made heterogeneity of CFS. The next thing, one thing I would like to ask you regarding that is, I'd like you to look for where the proof is that all these diverse, biologically unrelated conditions should be considered one clinical entity or one spectrum of illnesses. There is no scientific proof that validates that. It's an invalid clinical entity that needs to go away. As far as the evidence base, because of all these definitions for all these years, the evidence base is so polluted with unrelated definitions and unrelated cohorts that you need a Ouija board to read it. It is impossible to make sense of it. I'm going to give you one example. There's a Cochrane study, well respected. It was used to look at CFS. Is there a clock someplace I should be paying attention to? Okay, thank you.
Well, you could have finished your sentence if you'd wanted to, but
the evidence base is fatally flawed. Look at the Cochrane study for CFS that proved that CBT was an appropriate treatment for CFS. It included studies which had fatigue for 6 months, for 3 months, for 4 months, no other criteria. It included multiple definitions, but as long as they met those criteria. And so it was on the basis of that study that we now have, that was one of the studies that now shows CBT is appropriate for these patients. It has nothing to do with us.
Thank you so much. I appreciate your comments. The next person is Eileen Holderman, who I understand is speaking for herself and somebody else, so she gets 6 minutes. So